So thank you very much, Dale, for this invitation. Great pleasure to be here in Sydney, of course. PET and brain tumors, that will be, of course, gliomas primarily. We talked about meningiomas this afternoon. So I can maybe, no, yes, I can. And again, this is our layout. We have 2 cyclotomes in radiochemistry and 9 scanners. One of them is the HRT scanner I told you about this morning. Our oldest is the Biograph 64. We are going to upgrade that next year to a vision scanner, and then we're also going to get a new MRI scanner, so now we will have 10 scanners. So we have lots of scanners. Scanner time is not an issue. In Denmark, we work very short hours. The department is completely empty at 3 o'clock or 3:15. And that's because in Denmark, we don't have housewives. Unless housewives are from different countries. They are not Danes. So all our women, and most Danish doctors are women, have to rush home to get their kids in the kindergarten, because that's where we have the kids. So all the women are working. For brains, and I'm dedicated for brains, so I only do brains. So this is our approximate brain production and the different traces we're using. A lot of it is FEG, that's mainly dementia. A little bit of epilepsy also. Fluorescent tyrosine is about 400 years. We do FEP2I for dopamine transporter imaging, which is an excellent tracer. We started up last year. It's in great demand. PAB about 150. That's also amyloid imaging. Phototox 40 a year, perhaps 40, 50, and we do water PET for chronic ischemia. So that's the Diamox test. Amino acids and amino acid analogs. Look at the guideline we have published this year, actually, where everything is written down. So you just have to follow the recipe and you can do the scan. There are 3 essential amino acid analogs. So it's fluorescent tyrosine, methionine, and fluodopa. And we all assume that they more or less give the same performance clinically. Of course, methionine is C11 labeled, so you have to have a cyclohone nearby. Half-life is 20 minutes. You can do 1 production and maybe do 2 patients or something like that. It depends how many patients you have. Fluodopa is coming up also, and part of the reason is that they are starting to synthesize fluodopa with a new target, so you can actually get a larger yield than before. Before, 1 production would give you 4 patients, and now you can actually do quite a lot of patients. And that was the reason why we started up with fluorescent tyrosine, because at that time when we started up, that was in 2011 or something like that. That was the target to go for if you wanted to have a large production for a lot of patients. So we are producing FET only once a week, and then we collect all our patients there, and then we can spread them out on all the different scanners. So, so that gives a lot of flexibility there. And we do between 6 and 14. It varies a little bit. The amino acid analogs are upregulated in gliomas, and they cross the intact blood-brain barrier, which of course is a huge advantage. It has also a low uptake in healthy brain, so you have a large target-to-brain ratio, and it's possible to detect tumor infiltration and also to see low-grade gliomas. And that's of course the big benefit compared to FEG. And here are a couple of examples. So here you have an astrocytoma grade 2 with signal change on T2 weighted MRI. You can't really see anything on FEG, but on PET, you can see the clear signal of the tumor. Is this recurrent glioblastoma that you're seeing here? Difficult to see on FEG, not so difficult with FET. So you have this large contrast, which is very nice. This is how we do the scans. You have to fast for 4 hours, take your regular medication. There are 2 ways of doing it. You can do either a static acquisition of 20 minutes after injection, or you can do a static acquisition as part of a dynamic acquisition. Then, of course, you fuse to T1 post-contrast and T2 flare, and you put in your reference region here, banana-shaped, crescent-shaped, in the healthy-appearing gray matter. And then you multiply that value by 1.6 if you're doing FET, and then you can place a sphere or something around the tumor, and then you threshold at 1.6. So that means that everything above 1.6, that's your tumor, and that's also your biological tumor volume. Of course, you can also get sort of a mean uptake compared to the background, and you can also get a peak, so the Tmax divided by B. And this are usually the metrics that you're interested in when you're using this tracer. If you are suggesting targets for biopsies, of course, it's the most active spot that you'll be pointing out. There are different threshold values. Some use 1.8. That's sometimes a post-surgical or post-radiation therapy. They sometimes use 1.8. For methionine, 1.3. Fluodopa is not really established, maybe 2.0. These thresholds are determined in an old study that's 20 years ago old, performed on an ECAT scanner. And of course, it has lower resolution. So that means if you're using these thresholds, you have to be sure that you are standardizing your image reconstruction to that old resolution, which is about 5.5 millimeters or so. There have just been another biopsy control study suggesting still 1.6 for high-grade gliomas. For low-grade gliomas, they actually had 1.4, so slightly lower threshold. But it's very difficult to make these biopsy control studies. So if you have good relationship to your surgeons and you think they can make one, you can do something important. Anyway, if you do dynamic studies, you can look at a curve pattern, and you have this early peak and then a washout, which is sort of a malignant pattern, and then you have a continuous uptake, which is supposed to be sort of a more benign pattern. And these correlate with tumor grade, but also with IDH wild type, for example. So this has prognostic significance. We are doing a little bit in terms of automating the processing, because I'm doing the drawing myself, and I think it's extremely boring. So I would really like to have that fixed. And what we are working, this is actually sort of a mean of the distribution of patients that had very little active tumor. And what we did was simply to mirror the activity across the midline. And this is all in standard space. So this is sort of the distribution of sort of expected activity. And you can see it's quite filtered. And this is a standard deviation map. And what we do is we put in a binding box of a sort on both sides above the insula. And then we look for the 80% most active areas. And you can see what happens is that if you have disease, in one side, you get a very small area, and you get a larger area in the side that doesn't have disease. So you can actually use the size of these reference region as a pointer to where the healthy region is, because it'll be smaller in the diseased side. If that doesn't work, then you can look at the Z-scores. The Z-score, so that is how large activity do you have here compared to what you would expect. And of course, you have larger scores if you have your healthy region opposite where the tumor is. And we've tested that in 183 patients, and we can actually get a precision of about 98%. So that could be something to work on there. But we're still testing on more patients. Yeah. This is MNI space. So everything is moved into MNI space, and that could be a big concern because you have patients with tumors and there are things that are missing and things like that. But actually, it's remarkably robust. So they're more normal than they're abnormal. So that actually works. And again, this is just something that helps you. So if it doesn't work, then you could just draw it by hand. So even if it just works in 90% or something, well, you just have to draw 10% instead of 100%, and that still helps. So actually now we are actually dividing it up into quadrants instead, because you can of course have a butterfly glioblastoma that goes to both frontal lobes, and then you shouldn't take part of that. And again, the point here is that you can rescale your images to the background area, because that's actually sort of one area where you can make a mistake, and that's multiplying by 1.6. I mean, that goes surprisingly wrong all the time. So this way, everything would be in the units of the background, and that could increase the clinical adaptation if people are a bit uncertain about where to draw these things. You can standardize the metrics, the presentation. So like, what does the blue color mean? How should you present these data? Also standardized between readers, between scans, and well, we want to have a sort of full automatization at some point where we can also have the tumor drawing. Of course, that's the whole idea. And you can also do the so-called parametric response maps. That could be interesting. And we're working on also automating that. So the idea is that technologists, they throw the PET scan and the CT scan to a server. The server looks for old scans, bring them in, calculate everything, and then present the data the next day when I'm doing reading. So a little bit of service would be nice. Parametric response maps. We have looked at 2 scans done within a week in the same patients. And then if you look at the side of the brain that hasn't got a tumor and subtract those 2, then you can see, then you get these Gaussian curves, and the 95% prediction interval is 0.02 tumor to background ratio values. So that means everything above that or outside that would be progression, or within that range, that would be noise. And again, you simply co-register the two images that you have and then subtract them, and then you can reduce everything that's sort of within this range, and then you get areas that are either increasing or decreasing. And that's something you can see over here. For example, this is, I think, medical treatment for low-grade glioma, and you can sort of spot areas that increase and decrease on chemotherapy. So that could perhaps help a little bit if you have discrete changes. You can't really decide, is this a change over time or isn't it? And then you can maybe have some support. They also have some pitfalls, of course, with these images. And then if you have, surgical changes or something, gross changes in anatomy, you can get sort of strange edge artifacts. So it's probably best to do for low-grade glioma. But that's something we're working with at the moment. Anyway, I'll be talking mostly about glioblastoma because that's actually what's sort of dominating our production. So this will be the typical time course of the glioblastoma. So it starts with some symptoms. It brings the patients to an MRI. The patient gets scanned. Oh, there's a tumor. We need section biopsy. And you have 72-hour acute MRI after that, postoperatively. You get histology, MGMT status within 20 days. We have an MRI also radiation therapy. You start with STUP regime, adjuvant, temozolomide, and then you get into sort of surveillance phase. Usually our first MRI scan is first after 3 months. So we have this MRI at radiation therapy, but nothing in between. And then there's a whole question, what do we have here in this phase? Pseudoprogression, early treatment failure. Then you have more late treatment effects. Is it recurrence or what is it? If it's recurrence, then should you resect or what should you do? And maybe you give temozolomide reinduction and maybe second-line chemotherapy, and that would be bevacizumab and Copenhagen in Denmark. So that's the monitoring phase, you might say. So early on, would we benefit from second-look surgery? So here's a study from Germany. A patient has a glioblastoma, very active here in the frontal lobe. My guess is about 30 milliliters. They resect the patient. There's nothing on MRI, but there's still a small remnant here, about 3 milliliters. They re-resect, second-look surgery, confirm that it's glioblastoma tissue. So should you do this or not? Is it worth it? Worthwhile effort? 3 milliliters doesn't make a difference? Well, we don't know until that study has been done. But this is some prognostic data that we did on 146 patients with glioblastoma that had fed at radiation therapy planning. So this is before they only had surgery. They didn't have radiation therapy at this time, or any chemotherapy, or anything that could modify the activity. So this is just remnant residual tumor after surgery, of course, and of course there can be some post-operative changes also that we can put in there. So in this model, we include the volume, as you can see down here, at FET at that time, and this is the survival probability. And we have actually sort of two prognostic group, one younger, so good prognostic group, younger, MGMT protein negative, that's promoter positive, and they have a good performance score. And then we have an older, more poorer prognostic group down here. That's these guys. So if you're in the good prognostic group, that's this one here. It doesn't seem that the tumor volume has a lot of effect on the short run. So this is at 6 months after radiation therapy. So it seems most of them are alive, although you have very large volumes, but the volume effect sort of kicks in after 18 months. So this is this curve you can see here. So the larger your biological tumor volume, the lower the probability of survival is. And the other group here is the poor prognostic group, and you can see that the volume kicks in very early here, already after 6 months. You can see that the survival probability decreases with volume, and after 1.5 years, not many are alive. So before we were talking about 3 milliliters, does it make a difference? Well, you would move somebody from here to here. So I'm not sure you would be able to see it. So if you had to modify something post-surgically, you would have to move people 50 milliliters or 40 milliliters at least of tumor tissue, probably in that range. That's just the hypothesis. Of course, you need to do the study to see that it actually works, but you need also to put patients in with a poor prognostic group. This is multivariate, of course. So when would it be important? Well, this is, for example, an anaplastic oligodendroglioma resected with 5-LA, and MRI says complete dissection because they removed all the contrast enhancement that was here. We do radiotherapy planning, and we can see that they've left 50 milliliters of tumor tissue. Of course, the non-contrast enhancing component. And we call the neurosurgeons, and they resected this patient actually to remove this large component. So sometimes we can find some of these patients. Also in childhood tumors, this is an early postoperative PET MRI scan. So this was done combined in a 3-year-old boy with an atypical thyroid rhabdoid tumor. These are very special tumors. And it was done acutely, so they knew that they had left a remnant tumor tissue down here. They didn't know they had left something here, and this was confirmed to be tumor tissue. So it can influence the surgical extent and areas they go to remove. We have looked at also with the early postoperative MRI on 22 children, 27 scans, and they all had dynamic PET MRI. And it gave clinically relevant information at 11 out of 27, but it actually only changed management in that one patient I showed you before. We could see there was an increase in diagnostic accuracy, that PET particularly gave more specificity compared to MRI alone. It might do something there. So, of course, this is PET fit at radiotherapy planning, and of course, it's particularly important because we can see the tumor infiltration. So in a patient like this that doesn't have any contrast enhancement, of course, getting a PET scan that can show you the tumor makes a difference, and also particularly in the low-grade gliomas where you don't see any contrast enhancement, that's also important. One thing, because we have this PET MRI scanner, one thing we have sort of been interested in to see, should we do multiparametric PET MRI? Should we do more than just standard MRI and then standard PET? Because in that case, you know, you could just do them separately. You didn't have to do them together and get an expensive scanner like that. We have thought that we actually thought initially that the interesting part would be to look at the late effects. We are dominated by questions of contrast enhancement. Is it really tumor, or is it just a treatment-related changes? So we looked at the late effects first, and it can look like this. So this is a glioblastoma patient, 2.5 years after radiation chemotherapy. T1 MRI finds a new lesion here, contrast enhancing at the ventricular system, and they ask, is this tumor tissue? And we can say, well, it isn't active, so we don't think it's tumor tissue, but there's something over here. What's that? Oh, yeah, that's where you have the tumor. So it's sort of anterior to the resection here in the parietal lobe, and it's actually infiltrating into the insula, as you can see here. There's very little contrast enhancement, maybe a small speckle there, but you stand there with 12 cubic centimeters of tumor. So that's likely to be the nodule is radiation damage, but that is the recurrent tumor, of course. If you look at the literature, and the largest study is by Galdix from 2015, they have 132 gliomas, and they have a threshold here of 2.3, and that, from a static PET point of view, that gives 0.68 in sensitivity, quite large specificity, and an average sort of accuracy. If they do dynamic PET, they can increase that. But we really don't want to do dynamic PETs because it takes too long time. We want short scans. So maybe we could do a short 20-minute PET MRI scan if we add something additional. The problem is, if you look at his patient group, it's a mixture of a lot of different things. I mean, only 40% of glioblastomas. He has grade 2 tumors that never had radiation therapy. So, I mean, if they have some progression on MRI, it's not going to be radiation damage. It's going to be something else. I mean, they only had surgery, so, you know, it's a different problem. So it's mixed grade, mixed histology, MRI changes, post-surgical, pseudoprogression, radiation necrosis, a lot of different procedures, heterogeneous treatment strategies. Some of them had sort of seed implants and brachytherapy, a lot of different things. So not really sort of your standard group of patients that we are seeing, not Stupp's regime, not only glioblastomas, a mix of different things. So we thought we need to look at our own data. So we looked at our own data, and it's just been published here. We looked in our archives. There was about 400 glioblastoma patients. We thought, of course, there was a lot of patients that didn't go into the study, but we ended up with 146 glioblastomas, about 168 scans. They all had just a 20-minute scan, and it was all 6 months after radiation therapy and 3 months after any surgical intervention. 95% had started adjuvant temozolomide, so most of them had Stubbs regime. Our reference was either histology or MRI follow-up to progressive disease for a minimum of 6 months, and that was on 64. And some of them had first line, and some of them had second line therapy. We found about 11% had treatment damage out of those, and that gave the best parameter was the maximal activity with a threshold of about 2.0, and that gave extremely high accuracy, as you can see here, 95%. So from that, you would say, well, this wouldn't be the patients you would want to be interested in doing multiparametric PET MRI, because what benefit would you have from doing, say, blood volume imaging or spectroscopy or something like that? I mean, PET actually gives the whole answer alone without having to have any aid from anything else. You can do just with that. We also found this that the activity of the tumor was also prognostic for the survival of the patients. And we found some other things actually that were a bit interesting. We found, for example, that we have a verification bias in our data. Verification bias means that the PET data determines whether or not the patients are going to get a resection. So, if you have an MRI scan, it's contrast enhancing, and then you have a PET scan that's very active, then everybody becomes alerted, and then they go for resection, and then you get biopsy verification. So that means if histology was our gold standard, we would only find 2 recurrences, which is about 2%. So, that sort of directs whether or not you're going to get histology. We found out that the histology groups, they had a better performance status, they were younger, had more superficial tumors, and also a higher PET uptake. So there's a verification bias there. So it was important also to take the MRI group in. In that group, we found 22% that had recurrences, and they had a poor performance status. They were older, deeper tumors, and lower PET scan. So we combined the two. And this MRI follow-up group, of course, we also had some patients that got Avastin, but we only included patients that progressed. If you respond on Avastin, well, you can't really use the MRI for anything. So it's only progressive disease on Avastin, and those that didn't, or those that responded, the PET patients there looked like the ones that we included. So we thought it was okay. The other thing is a question that comes up now and then is whether or not PET is useful in non-measurable lesions. So if you have just a speckle or just a spot, can you use a PET scan to evaluate whether or not you have active tumor tissue? And you can. We had 34 lesions that were non-measurable. 3 were false negative, but we had true positive at about 90%. So you can use PET even though you have a small contrast increasing. So again, it's not really a target for PET MRI with advanced MRI. This is just to show you some images. We had this was a sampling error. This patient with a glioblastoma was originally resected, and that's the yellow cavity here. And we did the PET scan, and we can see there's activity here in the orbital frontal cortex and also laterally. And they made a new resection, and the new resection cavity is in red. And you can see how they took a lot of effort to remove brain, but not the tumor. The tumor wasn't removed, and it came out, of course, with reactive changes because it didn't go to the tumor, and the patient progressed after 2 months, and then he died. So we had to take these things into consideration also when we evaluate the patients. This was a false negative, small non-measurable change here, larger diffuse change, Tmax was 1.9. It turned out to be tumor tissue. This was a false positive, quite active. This sort of star-shaped contrast enhancing looks a bit like scar tissue, but was very active, 3.1. We repeated the scan 4 weeks later because this patient had a previous history of pseudoprogression, was resected for that about 4 months after radiation therapy. So we were a bit uncertain about that. So we repeated the scan, but it was still very high, and it was actually increased a little bit. So we thought, well, that would probably be tumor tissue, and the patient was supposed to be re-resected but didn't want to. So we did MRI controls, and you can see how the tumor fades. So this was a false positive. This is just to show you an example of radiation necrosis. This is a patient who had re-radiation, of a grade 3 tumor. And that was with stereotactic margins. So that was just 2 millimeter margins around the PET active area here. And this is the biological tumor volume, and it starts here around 10. Then it goes a little bit down, and then it just starts growing. And it continues to grow for 9 months, and then it spontaneously declines without any treatment. At this point here, the patient was reresected between these 2 scans, and they show just reactive changes, and you can see how it just goes on PET, and also MRI. It goes outside the radiation field, and then it spontaneously disappears again. And that's, of course, you can say one of the things we don't know so much about, and that's what is the spontaneous evolution of these changes. I mean, when do they start? When do they stop? When do they peak? How long time do they last? And that's particularly a problem in pseudoprogression, actually, as we will come to next. Well, as you know, that's something that happens in 50 to 60% of the glioblastoma patients. And 30 to 40% or 30 to 50% will resolve spontaneously without any change of therapy. And that's a big problem because the patients have progression on MRI, and then either they get a resection they shouldn't have had, for example, or they're changed to second-line therapy, which they shouldn't have had because what they're given already was fine. Or they could also be enrolled into a trial where they get experimental chemotherapy that always works. No matter what they give them, it's going to work because it's just reactive changes. And so here's an example here. This is from the literature. Of course, it's most common within the first 3 months, but you can see them also after 6 months. And so you have this lesion here. 2 weeks after, you have contrast enhancement, and then you have 10 weeks, you have this. And usually this is when we would scan the patients. So you would see something here, it looks like progression, and then the patient would be treated here for something. If you're very careful, then you do a follow-up scan after 2 months. This is the scan you see here, and that's also progressed. So even if you did a control scan to be extra careful to see whether or not the lesion actually changed, you would also do something wrong if you treated the patient here. If you just follow the patient up, you can see that it disappears spontaneously after several months. So this is a huge problem, and we haven't really got a good description of how it's evolved, but it's a big problem. So it's ill-defined. Histology is the gold standard, but it's very difficult to interpret. I mean, how much tissue do you need? Usually what they do is they open up, they take 3 biopsies and send that down, and then 2 of them say reactive changes. Some of them have 3 tumor cells in one corner or something like that. So what does that mean? And there are many different interpretations of this, often a mixture of different things. And it's being addressed by the RANO at the moment, but you know, it affects all the trials that we're doing, basically. So this is the data from Galdex, and here's 22 patients with glioblastoma, and he has extremely high sensitivity and specificity, and this is just an static scan. He did curves also, but it didn't make any difference. He could do that just on activity, and he has very good data here, as you can see. So actually, I didn't think that pseudoprogression would be something that we should be interested in because, you know, it works really well, right? Except that when we start to get complaints from the surgeons because they're resecting the patients, and they said, oh, it's very, very active, and you only found reactive changes, so what are you doing? This is one case where you can say that, you know, it's quite clear. This is after 4 months, also 5 months of MRI, and they have some MRI changes here. They can't really interpret. And again, we see this diffuse infiltrating tumor, which is also gone to the other side. As you can see, there's not much to look at MRI. Also, the flare sequence, not so much there. You can see diffuse flare. So this is one true positive, but this is actually a false positive. We looked at this patient with a glioblastoma at radiotherapy planning, 29 milliliters of tumor tissue. Looks like that. 3 months post-radiation therapy, we have this image, and for me, it looks completely like active tumor tissue. The surgeons went in, said it was sort of firm, and histology showed reactive changes. But I mean, there's no way of seeing in this image that it should be tumor tissue. So, false positive. Well, that can be very tricky. So we looked at all our GBM patients. Like the others, they had radiation therapy that all started adjuvant temozolomide, and we all 3 months post-surgery. We had 83 of those, and it was PET scan based on something on MRI from 1 to 6 months, and we divided it into 1 to 3, we had 50, and 1 to 6 months, we had 33. So sort of early and late stage pseudoprogression. Reference standard was histology, which can be problematic. And we also had MRI follow-up. It had to be either progressive disease or stable for a minimum of 6 months. We also had 45 patients that had radiation therapy before. So we had like a baseline scan of radiation therapy. Was there something there? Would it be increased or decreased? But we used something for that. And for that, actually, we compared also to 7 to 12 months. And these 51 patients was from the previous study that I showed you. And they also had histology and MRI follow-up. And these are the results. So if we just pool all the patients, this is the pool data, all 83, we had about pseudoprogression, about 20% of the patients. And there's absolutely, there's not a significant curve. So we can't separate the two groups. It was not significant. If we look from 7 to 12, also pooled, we have highly significant changes. So there seems to be something going on after 6 months. So before 6 months and after 6 months. And again, we didn't find any difference if we saw just histology, just MRI, or the early phase or late phase. It was, it didn't make it. It didn't show anything. These are the data. So this threshold down here is 0.8 or 1.8. And you can see all the blue ones are pseudoprogression, and all the red ones, that's recurrence. Again, there's simply no way we can put a cutoff in the pseudoprogression phase that would separate the two alone based on activity. Much easier over here. So there seems to be something going on after 6 months. It's simply something different. Again, remember there's kind of a verification bias. So if you have a very active tumor, it will drive the patient towards some sort of resection or biopsy. So I'm quite sure that it's correct what we're finding over here. I mean, you have very active tumors there that would drive the patient into getting some sort of histology out because it looks dangerous. But when they do it, they find tumor tissue after 6 months, but not before. Then we looked at the other data, and again, the data in the literature is also a mix of everything. They have, you know, before 6 months, after 6 months, they have some grade 3 tumors, different kinds of treatment and all that. So, but they're very kind to publish the patient data, so you can go in and you can sort the patients out and only take those that fits with our selection criteria. And if you do that, you get these results. So actually, there are 2 German groups here. So Kepia, Galdix, and Werner down here all come from Cologne, Jülich, and they all have good results and a threshold around 2.0, 2.3. Then there's this other guy here. He's from another part in Germany. He has 3.3, so much more active, but still, and also areas that aren't really significant. And then there's us down here. We have 1.9, but don't find significant changes. So of course, you can pool all this data and get a threshold of about 2.6 and sensitivity, specificity around 80% or something like that. But we don't really know why we see these differences. I mean, could it be that they interpret MRI a little bit differently? Could it be they get a little bit a different kind of surgery? Pathologists look at things differently. We don't know what these differences actually cover. But anyway, we know it's a problem. And this is when we compare to radiation therapy. So this is the maximum activity. This is the biological tumor volume. And you see, it doesn't really predict anything. You can have a low activity. It can go large or high up if you have a recurrence, for example, the recurrences. Or it can also decrease. The same, this is pseudoprogression. So it can increase and decrease, and the same goes for the biological tumor volume. So it can get smaller, it can get larger, it can do anything like that. So there's not really any good separation based on a previous scan, unfortunately, because then we can do another scan. We should focus on pseudoprogression when we're doing PET MRI to see if we can improve the diagnostic accuracy there. And what we're doing is just sort of a standard MRI sequence. Standard MRI for follow-up in Denmark, that's T1 with contrast, T2 flare, and a regular T2. So that's all they get there. So that's about a 15-minute program, and we put a little bit extra on. And what we put on is DCE, or you get the blood volume and permeability, but we're not using Tufts model or Tufts extended model. Tufts extended model is what you get on most MRI scanners because it's been criticized not to be particularly reliable, and we believe that. So we have our own sort of model. We also could look at advertisement labeling, and we have tried a little bit to look at the Hadamard time-encoded pseudo-continuous hallucinating sequence, which is an impressive piece of mathematics. Unfortunately, it doesn't work very well, but it's really, really impressive. So we're looking at that. And again, the concept is we have the patient in the scanner anyway. So if you have some interesting sequences, you know, if you just set them off, you can compare fluorescent tyrosine to whatever you get on MRI. And you can make a direct comparison simultaneously with the patient in the same physiological condition. If you do it at different time points where the tumor could be progressing, or you could have treated the tumor, it could have changed some way, one way or another. So it's very nice that you can do it simultaneously because the physiological condition is the same. And well, our system is that we scan and then we again throw the data to a computer. The computer calculates DC and all the other stuff also, and then comes out with a sort of a quality control report where we can see the fit, the arterial input function, and these other things. Does it look reasonable? And we can take that into our quality assessment, and we want this to be in place the next day when we're reading the scans. I'm not very good with things that happen next week or something. You can look at the scans next week. It doesn't work for me. I have to have it all at once, and then I can evaluate blood volume, permeability, fluorescent tyrosine, MRI in one go, because that's what, yeah, it's clinical. So here's some examples. This is a patient with a glioblastoma at radiation therapy planning. So they've done a nice work here. They removed all the contrast enhancement, but they still have some residual here, which we draw in. Then 6 months after radiation therapy, the patient gets something here on the other side, faint contrast enhancement. We do PET, MRI, DCE, and you can see that the tumor actually grows. There's maybe 2 weeks between the two scans, so there's a progression. Also here, we also send that to our new radiologist to measure this out. We see very active PET uptake here, and we actually also see progression on the side that was radiated. So there was treatment failure over here. If you look at the blood volume images, you see increased blood volume where you have contrast enhancement, but not where you don't have contrast enhancement. So blood volume in our implementation here is not really something you can use to see non-contrast enhancing diffuse infiltrating tumor tissue, but it can see the things that are contrast enhancing. Here you have the Ki, that would be the permeability. So increased permeability where you have contrast enhancement, but not on the other side. So they're showing different things. But it's interesting that the blood volume can sort of support tumor tissue in areas that are contrast enhanced. Another case, again, this is 3 months after radiation surgery. The patient has this new lesion in the frontal lobe and this lesion in the close to the ventricular system. There's also a flare signal change. This is a lower slide. There's some flare signal change here also, as you can see. This is very active. Tmax is 2.4. You have increased blood volume in that area. That would indicate tumor tissue. So 2 points, 2 points. So increasing contrast enhancement, increased amino acid uptake, and also increased blood volume. This lesion here is more dodgy. It has a lower uptake, and if you notice, there's actually contrast enhancing areas here that don't have uptake with PET. That alarms me that this could probably be some reactive changes. Also, you can see no blood volume increase in the lower part, maybe something in the front. Another, if you go to the lower slide here, you have an area here with diffuse infiltration. It's actually this lesion here down, infiltrating down towards the basal ganglia, increased, but no blood volume increase. On follow-up, this lesion diminished, faded out on MRI, this one increased. So I'm sort of gravitating towards that there could be something interested in the combination of the two. So you have PET that can tell you something about diffuse infiltration, first and foremost. And you have blood volume imaging that is good maybe to rule out active tumor tissue if you have something that's contrast enhancing, but only in that area, not in the other area. So the combination of the two could be interesting. And DCE, well, that's only contrast, and it's something you do anyway. It takes an additional 8 minutes, I think, 6 to 8 minutes in our implementation. So it's 5 minutes for the contrast enhancing dynamic scan, and then we do 5 flip angles, so-called flip angles to quantify T1. So I'm gravitating towards that, but it's sort of evaluation in the clinic, you know. Anyway, that was pseudoprogression. Now we're sort of going to treatment monitoring, for example. And of course, there are these studies here where you give temozolomide to low-grade gliomas. And if you look at the flare volume, you can actually see sort of it's constant. It doesn't really change here over 24 months. And you treat the fed volume here, and it becomes inactive. And you can see that very quickly on the curve here. Conversely, you have a patient here also with stable MRI volume on the flare sequence. You have an initial response, but then you have malignant transformation over here, and you can see the activity returns. So that's one way of using FET also. This is one of our cases here. They're asking if there's active tumor tissue based on that. There's some contrast enhancing. Patient has oligodendroglioma, and yes, there is active tumor, as you can see here. On follow-up, after a year in adjuvant chemotherapy, they're still uncertain about whether or not there's active tumor here, and it's clearly grown and it's filling in the cavity, still not contrast enhancing. Yes, you have a large tumor here that's going across, as you can see here, but you also see the distant spread into the vermis over here without any contrast enhancement, perhaps a signal change and flare, a little bit like that. But anyway, often the vermis is one of the places where you would see recurrence. It goes into the ventricular system, swims around a little bit, and then it implants, particularly there. Pseudo-response, MRI, butterfly, glioblastoma, contrast enhancement, increased edema, very active tumor. You give Avastin. After 12 weeks, it disappears. Edema disappears also, but it's still eating amino acids. We don't do this routinely, but we do monitor the patient now and then. And we also use it for whether or not we should give the patient a drug holiday. So this could be a glioblastoma patient, as you can see here. This is for radiation treatment planning, so active tumor at different locations. And the patient recurs and gets bevacizumab. This is after 9 months. There's no active tumor tissue. If you want to stop treatment at this point, well, at least there's nothing active, but of course it can rebound very quickly, but that could probably be okay. Oligodendroglioma, grade 3, treatment with temozolomide, stable on MRI, drug holiday. Well, I don't think so, because there's something active here. I think it's going to flare up if you remove therapy, and actually this patient got surgery, and that was confirmed that it was a recurrent tumor. What we do see is more sort of pseudostability issue, really, pseudostability. So this patient had a contrast enhancing change here in the meatus acousticus interna, and they wanted to know, is that a recurrent tumor? It's right there. And we say, no, it's not. Look, it's inactive, but there's all the other stuff. And you can see there's also contrast enhancing areas here, not active, but you have sort of flare signal increase in the temporal lobe that is constant, so pseudo-stable, but you have this active tumor that can move inside whatever that connective tissue component is or whatever. So you can have changes that are simply, you simply can't see on MRI, so pseudo-stable. This is another example of how we have used PET MRI with artificial labeling. It looks like this. They ask, do we have recurrence? I say yes, we didn't have recurrence. This is the blood volume imaging, maybe not as clear as before, but you can see there's increased blood volume here, increased permeability. They give the patient Avastin, and you can see it fades out, but there's still active tumor tissue. Yeah, and this is the Hadamard sequence. So that was the one that was very interesting mathematically, but didn't really work out, as you can see. So that's what we use it for. We can sort of evaluate some MRI sequences, if we have any, to see whether or not we think it's going to give something. And again, you have this combination of contrast enhancement, active tumor tissue, blood volume change, Hadamard, that doesn't work. And you can see blood volume change catches this area here, but not the cortical area, as you can see over here. So again, you can't do with blood volume imaging alone. If you want to have the full picture, you need to combine the two. So thank you very much. Yeah. Why I get a fat signal? Active tumor tissue, infiltrating active tumor tissue. The thing is with bevacizumab, we know that already, that it changes the phenotype of the glioblastoma. on some of the tumors, of course, so they don't longer need to, they don't make their own vascular system. Now they just use the vascular system that you already have in place in the brain and infiltrate it along there. So we can see, we have several examples of those. So completely stable on MRI, and then there's, oh, look at the active thing we have here. What's that? Oh, pseudoprogression or pseudo-response, sorry. Oh, sorry, yes. Oh, yeah, why do we have the, oh, sorry, yeah, why do we have that? Well, that's inflammation. Yeah, that's inflammation, but I think that we have different kinds of inflammation. So we have contrast enhancement on MRI, and you can have that in pseudoprogression phase or late recurrence. You can also have it in sort of immune therapy, and I think they look the same on MRI, but physiologically and pathologically they're different. There's different mechanisms going on. So the late radiation necrosis, that's more ischemic, inflammatory. The early is perhaps more toxic. So there's other things going on.
What cells are taken up?
Oh, that's the glial cells. The glial cells, well, it's astrogliosis. That's at least what they have seen. So you also see it in status in so if you have status for 24 hours, for example, then you can also see an astrogliosis and increased uptake there. So that's a little bit unfortunate that we have that. That would have been better without. Yeah, it confuses things a little bit. Yeah. No, L-DOPA? Oh, F-DOPA. No, I haven't, because we don't have the tracer. We could get it if we wanted it, but we have fluorescence basically. Fluodopa, I think it's a good tracer. It's interesting. Of course, there's a lot of uptake in the basal ganglia. So that's been one of the points of criticism that, if you have something that infiltrates into the basal ganglia, how do you know if it's tumor or just physiological uptake there? There's some still being discussed whether or not you should pre-treat the patients with carbidopa. So that adds something additional. The patient has to come an hour before and get that before you inject. And we don't want the patients in the department, we want them out of the department. So there's other aspects there. No, but I think, there has been reports of a larger uptake in fluodopa, in particular low-grade gliomas. So perhaps it's better to do something. So you can't do curves with fluodopa. But of course, if you have some Parkinson patients, you can put in those also. But we use P2I, which is a better tracer than fluodopa for Parkinson's disease, of course, because you upregulate your fluodopa in the early phase and downregulate the fat, so it's actually more sensitive. So I would go for that. But,
What we're doing, of course, there's a number of patients and that's whether that has an impact on overall survival, because we fall under that, we're not sure. But it also essentially allows us to do certain installation of radiotherapy, margin reduction of that as another strategy. So I don't think, and we're going through a typical step on a community basis versus then developing target modeling on an institutional academic basis. There's a lot of different.
We thought this was the hope to determine whether we have cancer.
Now the national study is to do category delineation, and there's a second arm, which is or third arm, which is looking at periphery. So we're actually going to be doing the dynamic study, which I think is